good afternoon and good morning to all of you. As Elise said, I am Timothy Lute, the Director of the Center for Best Practices at the National Governors Association. I have the privilege of overseeing our state policy team, which covers everything from health to public safety to energy and infrastructure, with just about every other policy topic in between. It's really such a pleasure and an honor to be with you at this meeting. The NGA Center has a long history of work in the drug policy space, going back at least a decade to our focus then on the crisis of prescription drug abuse. We are thrilled to host this meeting and to support American Samoa, Connecticut, Michigan, and West Virginia over the next year. And I would echo my colleagues' earlier comments, a special shout out to American Samoa for being up at 5 o'clock in the morning or thereabouts with such a strong presence. Really appreciate that commitment. During these 2 days, there's going to be a lot of great content, and I know we have several excellent presenters and leading experts in the field during this meeting. We're honored to have such a high level, to have such high level support from the federal government for this meeting. Their participation speaks volumes to the importance of the issue of stimulant use across the country. Unfortunately, we know there were 93,000 overdose deaths in 2020. 93,000, which is the largest single year increase on record. We are thankful to have the support of the federal government as the 4 participant states work to move the needle on overdoses and overdose deaths in their respective states. Today's keynote speaker is Dr. Nora Volkow, who is the director of the National Institute on Drug Abuse, NIDA, part of the National Institutes of Health, which supports most of the world's research on health aspects of drug use and addiction. Dr. Volkow's scientific research was instrumental in demonstrating that drug addiction is a disease of the human brain. And as NIDA director, her work has promoted research that improves the prevention and treatment of substance use disorders. Doctor, we're grateful for your participation and partnership, and the floor is yours.
Thanks very much, and good afternoon, everyone. And I'm very grateful that I'm given the opportunity to speak with all of you. And what I'm going to be doing is actually bringing some of the relevant points, because I only have 20 minutes, that relate to the science pertaining to psychostimulant addiction and how it can help us address it. And I say how it can help us address it because we don't have time in our hands. I mean, the urgency and the number of people that are dying is so large that we need to take action. You know, and I want to start with actually these numbers from the CDC that actually give us a very, very good picture of the problem in quantitative terms. It is the opioid crisis, the overdose crisis that now is no longer the opioid crisis, it's an overdose crisis for the past 2 decades. And we can see how it started with the use of prescription opioids, which here are in orange. And then what happens is that this was exacerbated with heroin, and later on it was exacerbated with fentanyl. And fentanyl is, since 2015, has been accounted for the very significant rise in overdoses. But in parallel to this very steep rise linked with fentanyl, which again is an opioid agonist drug that is much more potent than morphine or heroin, we see also a very, very significant and fast increase from overdoses associated with stimulant drugs. And the stimulant drugs predominantly reflect cocaine and methamphetamine. And the numbers are actually quite similar if you look at it from that perspective. But I do want to make a point that we already realized, and this is data up to 2019, that whereas these are coded as deaths associated with fentanyl or deaths associated with psychostimulants, it is also clear that in many of those deaths, there are more than one substance responsible for the overdose. And this is the reality that we are observing across all of the country. It's now harder to say that a person dies from a single drug, but instead is more drug combinations, which has in and of itself very important clinical challenges. The question is, why are we seeing a rise in cocaine overdoses, and why are we seeing a rise in methamphetamine overdoses? The first question is, do we see a parallel rise in the number of individuals that are consuming cocaine versus those that are consuming methamphetamine? This is data from SAMHSA to indicate the number of individuals that have reported use of these drugs in 2016, 17, 18, and 19 by age range. We see that the greatest increase occurs between 18 to 25 years of age. But we also see that for cocaine, there was not an increase there hasn't really been an increase in cocaine use. And for this age range, which is also the highest for methamphetamine, we also have not seen an increase in people consuming the drugs. when you look at those that are 26 or older, which corresponds in absolute terms a much greater number of people, we see that for cocaine, we also don't seem to see an increase in the rise of its utilization. For methamphetamine, on the other hand, we see a significant rise in 2019, indicating two things. First of all, that yes, the pattern of drug use is changing, but also that just increase in drug use is not solely, cannot account for the very dramatic increase in overdose deaths. And in fact, if you look at data that goes from 2012 to 2019, you see a 5 to 6-fold increase in overdose deaths. Whereas if you look at a similar time period, I don't have it here in terms of people increasing in use, you may see a 50 to 60% increase, not a 6-fold increase. And what we now know is that this increase in mortality is linked with patterns of use that are much more dangerous, but importantly, that the drugs that are being sold in the illicit market are also much more deadly. And here we have it, presented again from data from the CDC, showing the number of deaths associated with cocaine versus those with psychostimulants. In this case, the descriptor of psychostimulants predominantly reflects methamphetamine. You can see that what we have seen, all of the deaths associated with cocaine, but the majority of those deaths are associated with combination of cocaine and opioids. And in the case of people that are using cocaine, there is no tolerance to the opioids. So if these drugs are contaminated with fentanyl, as we're seeing currently across all of the country, then the risk of overdosing is much higher. In the case of psychostimulants, you see the very, very steep rise. And you also see that drug combinations appear between deaths associated with psychostimulants with opioids, predominantly fentanyl, are actually driving at least half of the overdoses, illustrating the challenge of what we are seeing is not only that more people are being exposed to cocaine and methamphetamine, but more people that may be using it are exposed to drug combinations that are very lethal, whether they are seeking it, or in many instances where they are actually not even knowing that these drugs are contaminated. Now, this is 2019. Now, as we are leading, because things have changed quite dramatically since 2020 because of the COVID pandemic. So what we knew then, we need to actually modify to understand how this very challenging problem that we're facing with the pandemic is affecting the substance use disorder field, and specifically the deaths and misuse of psychostimulants. The first question that we were all very interested in knowing was the possibility that with the closing of the borders from the pandemic in 2020, in March 2020, it will be much harder for people to bring drugs into the country. And we hope, perhaps expected, perhaps with a little bit of optimistic thinking, that we will see a decrease in drug use because people will not be able to access the drugs. Unfortunately, that's not what happens, and this is data from total drug seizures nationwide per pound in 2014 to 2020. And you can see clearly that in 2020, which is the year of the pandemic, a very significant increase for already a rising number of seizures in 2019. And the issue is even more dramatic in the case of methamphetamine. For heroin, we're seeing that the levels have been leveling off, which actually explains why overdose deaths from heroin, if anything, appear to be going down. But look at fentanyl. In the case of fentanyl, we've also seen a significant rise in the pounds of seized drug. And this is among the most lethal opioid drugs that are currently in the illicit market. And as I say, when you're comparing 2 and 2, you actually, which is done because combination of fentanyl with other drugs increases the profits for the dealers. This is a relatively easy drug to synthesize, whereas these drugs, cocaine or heroin, require cultivation. It's much harder to bring into the country. So within these changes, increases in seizures, which we can basically interpret to reflect that overall there is an increase in drugs coming to the country during 2020 and therefore more accessible to people. What is the question in terms of their use, particularly in a situation of so much stress, which we know is always linked when we have situations as this one with a higher, an increase in drug use and a relapse among those that have been in recovery. We have seen, using data from laboratories that measure the content of drugs in people that are sent either by treatment programs or from justice settings, that when you compare from two different laboratories, Quest Laboratory or the Millennium Health Laboratory, that the number of positive urines reported in 2020 compared to 2019 for the different months that you see here, this is the declaration of emergency, there has been a significant rise in positive urines for fentanyl, positive urines for methamphetamine, positive urines for cocaine, and positive urines for heroin. The Quest data actually shows it presents the data slightly different. It actually looks at the percentage of the differences between 2018 and 2019 in drug combinations where the urines had more than one drug. And I want you to pay attention to it because we can see a significant rise in combination of fentanyl with other opioids like prescription illicitly manufactured prescription drugs, but also look at the increases in amphetamines, which includes methamphetamine, a significant rise on those that have combinations, as well as other drugs like benzodiazepine. The same story is true for cocaine. So yes, we have seen an increase of these drug seizures, but also we are seeing that more people are being exposed to these drugs by themselves or in combination. So the question is, how does that translate in overdose deaths? And you have heard the numbers cited. This is the data from CDC that goes up to January 2021, which actually accounts for a long period, 9 months, 10 months, basically, of the COVID pandemic versus the 12 months that preceded 2020, which is actually just before the COVID pandemic. And in this case, you see 23,000 more people died from an overdose in 2021 at this point than in 2020. And this is notable because we were already extremely high. And this is by far the highest increase we have ever seen in overdose deaths in 1 year. It's important to look at the drugs that are contributing to these overdoses. And we can see the presence, as we have been noting, of synthetic opioids, predominantly fentanyl, but also look at the presence and the combination of methamphetamine. So yes, it is that what is driving overdoses is no longer accounted by prescription opioids. It's increasingly accounted by fentanyl and other analogs by themselves or in combinations with psychostimulant drugs, like methamphetamine. And also we're seeing people dying just from methamphetamine or cocaine. These are very addictive and toxic drugs. So with this panorama, where are we in terms of what the evidence has shown us? Unfortunately, if we're tackling the problem of psychostimulant addiction, we do not have FDA-approved medications like we have with an opioid use disorder, as was noted before my presentation. And this makes it very challenging because it can basically, medications for opioid use disorder can prevent overdose deaths. It's one of the most effective prevention interventions that we have. And we also have Narcan, naloxone, which actually prevents, reverses overdoses, preventing people from dying. We don't have anything like that for methamphetamine or cocaine. However, we do have evidence of behavioral interventions that work. And the strongest data comes from contingency management, both for cocaine and methamphetamine. Contingency management has been shown to be effective in reducing drug taking and in facilitating recovery. Contingency management by itself or in associations with other behavioral interventions like community reinforcement appear to have the best responses. One of the challenges, though, has been implementation. And the implementation requires, of course, as was stated also in the plan, that resources be provided for this purpose, as well as personnel that can deliver them. There's very, very exciting research going on, including, for example, a study that was published at the beginning of this year that showed the largest effect that we have ever seen in benefit for the treatment of moderate to severe methamphetamine use disorder with combinations of 2 medications that are currently available and used for the treatment of other addictions. Bupropion, which is used for the treatment of nicotine dependence, we combined with naltrexone, which is used for the treatment of opioid use disorder and alcohol use disorder, significantly improve outcomes. So this is an interesting development, providing that could, in principle, be brought into the clinic relatively rapidly. There are many other extremely exciting research tools and promises, but these, like, for example, the use of immunotherapies, vaccines, monoclonal antibodies, that what we'll basically do is create antibodies that they trap that drug in the blood so it never gets into the brain. They could be life-saving for methamphetamine overdoses or cocaine overdoses, and they could serve also for treatment. But development of immunotherapies, even though have been very, very fast for COVID, are much more slower and have been slower historically to bring into the clinic. There's also, we need to go beyond just focusing on medications, which are very, very useful, but in parallel, strengthen interventions that may enable us to get into the clinic faster. For example, in the whole area of neuroscience, there's been enormous advances in understanding how do drugs affect the human brain, and what are the functions that are responsible for the loss of control and the craving and intensity and dysphoria that these patients have to battle, and that leads them to relapse into drug taking. By understanding what circuits of the brain are implicated with these effects, we can use neuromodulation technologies that are based on electrical currents, magnetic currents, or ultrasound, or even light, to actually stimulate and strengthen those systems, or on the other hand, in other areas, inhibit them so that we can overcome the strong craving associated and hunger for the drugs. But we, as I say, and I started, we don't have time in our hands per se. There is an urgency that demands that we look right now of where the evidence is and deploy those interventions in ways that are sustainable. To me, there is a lot of evidence-based data already showing that treatment works, prevention works, but they are not being used. And this is very frustrating. So the question is, how do we incentivize policymakers to provide the resources that are needed to implement them and sustain them? So to me, one of the questions is doing economic research that actually documents the costs of not intervening, and basically contrasting that with the cost of doing an intervention. It's also crucial that if we are going to be successful in the long term, we need to develop models of care that are sustainable. For example, the use of pharmacies and telehealth options, and in certain instances, mobile vans, provide treatments in ways that are effective and much less costly, and also provide access to treatment in difficult to reach populations like rural areas. It is also clear that integrated health interventions provide tremendous advantages, including the fact that while we may not have advanced treatments for substance use disorder in many communities, across all of the communities, we have in general access to healthcare. So taking advantage of those systems to screen and deliver treatment becomes a very viable option. And again, as I say, there are many ways that we can expand and specifically target interventions so that they can be utilized and sustained, like contingency management, or the prescription of the new formulations of medications for opioid use disorder, which are beneficial in preventing relapse and actually show pretty dramatic effects when in preventing people from getting back into the reincarceration when they are in the justice setting. So, but where do we end? And I think that as we are actually addressing the urgency of the psychostimulant crisis, we need to highlight prevention interventions, because otherwise we're going to be chasing our tails. And we need to address the question about what is making people more vulnerable. And as a nation, we have seen that there is an increase in the mortality overall from all use of drugs that reflects what some have come to call diseases of despair, the sense that actually drives people to take drugs as a means to escape a reality that's very difficult. Those vulnerability factors actually start to arise very early in humans' lifespan, in childhood, adolescence, and can actually create the vulnerabilities that lead these individuals as they grow into young adulthood, into taking drugs and becoming addicted. And similarly, these adverse environments can lead someone who is struggling with taking drugs to relapse and to escalate in drug taking. And I take this last slide. I like to finish with this last slide because it shows us something that we have that can be either an asset or it can be a liability. Our social context, our support systems are the most powerful intervention that we have, both to prevent substance use disorder and also to sustain treatment and achieve recovery. However, when those social systems become punitive, when we stigmatize, when we discriminate, when we maltreat, then those social systems actually promote the use of drugs and relapse. And this can be seen in this very simple study with a very simple animal model, where the animal can either choose between a social reward, interacting playfully with another animal, versus methamphetamine. When they have that choice, they do not take methamphetamine. But if you punish the reward, then the animal rapidly shifts its patterns, no longer chooses the social reward, and instead escalates into drug taking. As we look ourselves in the mirror, I want us all to basically recognize that we can do interventions that actually can solidify our prevention efforts if we all work together to strengthen community links and to provide the support that's necessary to families that are struggling because of social and economic reasons, and also those that have been exacerbated during the COVID pandemic. And similarly, provide those support to people that are already battling with substance use disorder, whether it is opioid, psychostimulant, or drug combinations. And with that, I want to thank you for the opportunity to speaking with all of you. Thanks very much.